Yes.
Okay. Hello, everyone. My name is Gertie Wilson, and I am a volunteer with NAMI, Maryland. I will be your moderator for this session today. This workshop session is addressing blood-drawn barriers with Clozapine, presented by Dr. Deanna Kelly and Matt Glassman from the Maryland Psychiatric Research Center. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website. This talk will discuss current barriers to clozapine and teach the audience new ways to use point of care and novel technology to improve blood drawn barriers with clozapine. We will use a hands on approach to show how to use a new point of care device. If this is not the workshop you met to attend, please click the back button on your browser or click on the sessions button on the left hand side of your screen to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them in the Q&A on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenters after their presentation has concluded. We are pleased to offer closed captioning for this year's conference. Captioning is only available for attendees using a desktop. To enable captioning, please click on the CC icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video display will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, please post them in our chat and our technical assistant will address them accordingly. I'd now like to welcome our presenters for today's workshop, Deanna Kelly and Matt Glassman. Deanna, it's you.
Thanks so much, Gertie, for the introduction. This is the end of the day, one of the last presentations, so I hope that the audience enjoys some new information here. As Gertie said, myself and Matt are from the Maryland Psychiatric Research Center. We have much work and for many years been looking at the medication Clozapine. Many of you online will be familiar with it. Some of you may not. But if you do know Clozapine, you know that a group in Maryland has been very active in trying to advocate for safe use, better use, and breaking down barriers. So we're going to show you today some of the work that we've been doing, some of the new technologies and advancements with Clozapine, especially as it relates to changing the way we can do things possibly at the point of care and making treatment easier. So I'm going to start off by showing you our disclosures. I have been on the advisory board for a few organizations, Consult to Medscape, and while I receive nothing myself, our university receives some support with the use of some of these devices from Saladex and Athelis. Matt has no relationships to disclose today. We will not be talking about off-label, but we will be discussing brand names and FDA advice, potentially mentioning in the pipeline devices. So just to set everybody, I know we've been talking a lot this week and the schizophrenia has come up many times in this couple of days, but just setting the stage for treatment. We do know that medications become the mainstay, antipsychotic medications, the mainstay for treatment with schizophrenia. And there's been many advancements in recent years, and that's not the focus of the talk, but many new treatments are coming out on the horizon that you've heard about that might have less weight gain and less side effects, et cetera, which is very exciting. We do know that recovery is possible with schizophrenia. We have many of our clients and our patients who do well, but then some people have lingering symptoms, and about a third of people don't respond well to the treatments we have. And this is where Clozapine comes in. Many of you have family members or patients who are taking Clozapine, and it is the only FDA-approved medication for those who are considered treatment resistant, meaning they failed 2 trials of previous antipsychotics. This slide just shows us, this is really a figure that shows the efficacy of different antipsychotics, not all of them listed, and the higher the number, the better the response relative to a placebo control. And you can see on the left, the clozapine is the superior of the antipsychotics that we have. And like I said, it has traditionally been kept as a first-line agent in treatment resistance. And we like to use that terminology rather than saying a last resort agent, which we don't feel is the appropriate terminology. So clozapine is the first-line option when someone is failing their treatments. Just to set the stage, as we're going to be talking about breaking barriers, I'm going to talk a little bit about making sure people understand that while we're major and significant fans of the medication clozapine, it's not for every person. And we need to do a risk to benefit profile with each individual patient to make sure that we minimize side effects, that we are treating appropriately, and that we dose very slow so that we can make sure people don't have side effects. And we have whole entire talks on how to use clozapine, which are not the focus of today, but just making sure that people understand the risks and benefits of using and not using. There are some side effects that we watch out for. There's common side effects like increased salivation, sweating, metabolic symptoms. Constipation is common. We often will treat prophylactically for that. But there are serious and rare side effects. There's as you know, the low white blood cell count or neutropenia, and that's one reason we monitor, and we'll talk about the point of care device, but it's less than 1% of patients have that side effect. But there are some other side effects as well. Also, the decision not to use clozapine is a risk, because it is, like I said, this is a thorough consideration of the risks and benefits, but by not using a gold standard, guideline-driven, evidence-based treatment and not using that at the point of the time and point that it should be used in 2 failed trials, we are putting ourselves at liability, and we are not giving our patients the best chance of recovery if we are not using evidence-based treatment. So there's a risk by not using. Clozapine, though, is underutilized significantly in our country. It's used much more frequently in other countries for lots of reasons, including differences in monitoring parameters. But in our country, this represents less than 10% usage in most states across the country. Not all, but most states. This is from the Treatment Advocacy Center. This is from some data from quite some time ago, but it's really nice data that shows us generally what's happening in the states. In the state of Maryland, clozapine, even though we've been advocating and working hard in our state over a period of time, clozapine still remains utilized in only about 4% of patients, and treatment-resistant patients are expected to be about a third of our patients that we see. Often, as I mentioned, it's not used, but it takes too long to use it. The guidelines say 2 failed trials, but in some of the data that's shown out there, sometimes people wait to 4 or 5 trials. Sometimes they'll add antipsychotics before using it. And polypharmacy, the use of 2 antipsychotics, is actually higher than clozapine use in our population, despite it not being an evidence-based treatment in all situations. As I mentioned, this medication is arguably one of the most underutilized evidence-based practices we have in psychiatry. So we spent some time many years ago doing a survey looking at why people don't use clozapine, why our prescribers across the state aren't using it, and looking at barriers and solutions. And in fact, the clinical barriers of close blood monitoring, regular blood work, and the non-adherence to blood work are the highest rated barriers by psychiatrists in our state. Psychiatrists, nurse practitioners, and other prescribers. So it's rated highest on a scale of 1 to 5, rating the least burdensome to the most burdensome reasons why they don't use it. So I mentioned that blood draws and adherence to blood draws is the most frequent, and other people have found this as well. This is North Carolina data, but there's other papers out there that suggest that the blood draw, the logistics of the blood draw, become one of the most frequent reasons for not using. And in our country, the United States, the clozapine REMS system is a registration system that you have to register, and then you have to have absolute neutrophil counts or one of the type of blood cells, the neutrophils, values submitted weekly for the first 6 months. After that, it goes to twice every other week, and then once monthly. But so it is a burdensome to logistically line up all these blood draws. Like I mentioned, these are typically what's done after 12 months. You can go to monthly, but we don't do these often in the doctor's office now. We send people out. This requires a phlebotomist, and then it takes a few days to get the results back. So we have to, the timing has to happen. And sometimes physicians say this is just a lot of work, and families say this is a lot of work, and patients say this is a lot of work. So we want to break down this barrier. So we also sent out a survey looking at solutions. What would people like to see? How would they better treat their patients if they had different solutions at hand? And this is ranking. So the top ones are the highest ranked and best, most significant solutions. And using a finger stick or a point of care device in the doctor's office or at the pharmacy are the two highest rated solutions by clinicians. There's many other things like education, and we'll come back to that at the end. But overcoming the blood draw has been one of the holy grail searches for us, and we've been working in this area for quite some time. I'm going to go ahead and turn it over to Matt Glassman. I'm going to stop. I'm going to let him try to share the screen. Bear with us for a second as we switch. But I want him, he's been working with me for several years on this, and he's going to tell you about the new point of care device that's available called the Athelis Home. Matt, do you want to go ahead and share?
Is everyone seeing that? Can everyone see that?
Yes.
Yes, Matt. Yes.
Thank you. I'm getting the not being able to see anyone saying that.
Yes. Okay.
I am not, and it took me all the way back. Let me get to the right. Here we go. So yeah, as Dr. Kelly said, we've been working with Athelis and the Athelis One, or what's now called the Athelis Home device. We've been working with it for 5 to 7 years. And the device, it can provide a white blood cell count and absolute neutrophil count for monitoring purposes within 5 minutes using just a capillary blood draw, so a simple finger stick. 1 drop of blood, it goes into a test strip and will create a peripheral blood smear. And what the device itself does is it images that smear and sends those images off for hematology analysis. And then the results are then uploaded and reported through an online dashboard. The device is CLIA waived. You don't need to have a CLIA certificate to use the device. And results are easily reached. You can access the dashboard on any computer or even through an app. And really all you need to operate the device is an internet connection. You can connect it via Ethernet with the Ethernet connection on the device or by connecting it to Wi-Fi using a simple app. And what's really great about it is it's integrated with the Clozapine REMS system. Results from the device will be automatically uploaded into the Clozapine REMS, and as they're doing now with the patient status forms, Athelis will automatically complete those forms and upload them into REMS for you. So it cuts out that extra step of having to take those results and upload them into REMS. And so the device has been rigorously validated. It was tested across 100 patients, especially patients who were exhibiting drug-induced neutropenia. They've run over 30,000 ANC tests. Run on the device, and they recently got a Class 2 FDA device clearance in the United States. The one caveat with the device is I don't believe it's been approved to monitor ANCs below 1,500 yet at this point. So one little catch there, but they are working on getting working on testing in lower ANC levels. And when we first started working with the device, we collected a little preliminary data, doing some satisfaction questionnaires with patients and prescribers. At the time, we were running an open label Clozapine study. And so we started running, we were managing the venous draws for all the patients in our studies. And so we started doing the venous draws and the finger sticks during the first 4 weeks that the participants were on clozapine. And our satisfaction questionnaires asked about how worried patients were about doing the blood work, the pain associated with the finger stick versus the venous draw, concerns over the amount of blood that's taken, how they felt about the convenience of using the finger stick and the device, getting immediate results, and concern over having their blood sent out somewhere else. And we use a simple 5-point Likert scale for this. And so what we found amongst the patients is that really you can see at the bottom there, it was about really finger stick being a preferred option was really about 50-50. They didn't really have a preference for how they got their blood drawn. But they did see having the immediate results and being able to do the blood work right in the doctor's office as a benefit. So 95% of patients thought that getting immediate results would be helpful to their doctor. 85% agreed that immediate results would improve their treatment. And they also preferred not having other people handling their blood or having their blood sent out to a lab. We also saw that worry for getting the venous draw done was higher compared to the capillary draw. Concern over what happens to the blood after it's drawn and sent out. The concern was higher for that with the venous draw. The volume of blood and concern the blood draw on their health was a bigger concern with the venous draw, and pain was a slightly higher concern compared to the finger stick. And we also got satisfaction questionnaires from prescribers, and the results were they were pretty satisfied with the device use. Being able to use the device in the office instead of having to coordinate with a lab, having ANCs come back immediately rather than having to wait 24 to 48 hours. Ease of use, all rated very highly. Everything was almost 4 points or higher. And so there's a seeing the device as being convenient, easy to use, and improving treatment. Were pretty similar amongst patients and the prescribers. And so we discussed doing a live demonstration, but we decided that might take a little too much time, and I didn't really want to stick my finger for everybody. But instead, I do want to kind of show you the device and kind of the scale. So this is a device that's practically handheld. It's kind of like a tall Alexa, and it connects very easily. You plug it in, it turns on, you connect it to the internet, and you're ready to go. We've got our little test slides here. They're very small, they're very easy. It even tells you how to insert and which way to go. It's got a little magnetic strip here, which goes first into the device, and it'll grab the slide from you and pull it in so it can do the imaging. And what I did want to show you a little bit more is the dashboard, because that's really, the device is pretty simple and easy to use. But the dashboard, hopefully everyone can see that. And this is what the Athelis dashboard looks like, and everyone gets their own dashboard. It's password protected. The information is shared with anybody else. It's very simple to use. You enter your patients into the system, and they'll show up in your drop-down menu. You'll have trained operators for it. The training is very simple. It takes about 30 minutes. And then you register yourself as an operator, and there I am. And then once you have your test sample, it's in the device, you simply click Run Test, and you select the device you want to use. And then in approximately 5 minutes, your result is uploaded. and you'll go into your results page, and everything will be here. You'll have your white blood cell count, your neutrophil percentage, and your ANC level. Currently, nothing is this. We're not set up for the REMS push, but it will automatically be pushed to REMS as long as the prescriber and the patient are registered in REMS, and the prescriber has designated Apellis as a designee, which is very simple to do. That's all I'll show. I'll turn it back over to Dr. Kelly. I don't want to take up too much time flipping through them.
So thanks, Matt, so much. Let me just get over there too as well. So I think that this technology, let me maximize it here. This technology has really been a changer for us in being able to have people who wouldn't take clozapine before start clozapine. It's transportable, so our ACT teams around the state take those into the patient's homes, and it is cleared for home use now. So it doesn't have to be done by a nurse in the office. It can be done by other trained personnel. But as Matt had mentioned, and so we can take it into the homes. There are people who have these at home in their home setting. But most of them are done in the doctor's office. So there's a lot of potential for really breaking down barriers. I saw a question in the chat about plasma levels. So that's what I'm leading into next, because it's also another type of barrier. And so as most of you know, guidelines recommend that we are measuring plasma levels, and that plasma levels, the concentration in the blood of clozapine is associated with outcomes. So if we have a blood level of greater than what's referred to as 350 nanograms per ml as the blood level, we can maximize outcomes. Now, we don't always chase numbers, but if patients are not doing well or they're low, we would want to push the level. And there's different ways we can raise the dose. There's other ways to try to get higher concentrations, but that's typically what we shoot for, is trying to have, or aim for, is trying to have levels above 350 nanograms per ml. We do this usually once we start treatment every couple of weeks, and we usually look at this about monthly or a little less frequently in the study. If there's a time when there's an infection happening, a COVID-19, any other infection, plasma levels can go very high and toxicity can occur. So getting plasma levels are really important. Additionally, if someone stops or starts smoking, it can change plasma levels dramatically. So there's lots of things that can affect plasma levels that can both be on the side of being non-therapeutic, too low, or almost toxic, too high. Now, it's not a tight window like something like lithium would be. There's a lot of room in there, but it's still really important for us to be monitoring. But we don't often get these levels back in a reasonable time. So we'll often send for one when we see a patient in the clinic, but we won't get the level back for 4 or 5 days. And at that point, changing the dose when they're not in the office is hard. So if we were able to move towards a system, we also could do plasma levels at a point of care, it would be important. They're currently not part of the Apellis platform that looks at white blood cell counts and other looking at other measurements on the complete blood count currently, and other things. But there is technology coming, and I'll show you there is proved technology and moving towards a point of care device in this area as well. So this is exciting as well. So like I mentioned, clozapine plasma levels are recommended by the current guidelines. They're underutilized also mainly because they're not that helpful in the outpatient setting when they come back and take a long time to do that. And on top of all the other blood draws, this often gets put by the wayside. Here's what we currently do. So when a doctor orders a plasma level, it would be sent to a laboratory, and the laboratory would do two things that are in tandem. One is called liquid chromatography, and the other is the mass spec. And these what they do is they separate the components in the plasma, and then they provide the spectral. They can provide the information to identify the components and give concentrations. So this is how we typically measure a lot of things, specifically around blood levels. We use this LCMS technology. But this new technology that's available by the company called Saladex, and this is the MyCare Psychiatry Clozapine Assay Kit, that has been recently FDA cleared. It's to be able, these are kits that can be used on general chemical or clinical chemical analyzers in clinical laboratories across the country. So it could be used at our labs, but it also could be used in our hospitals. Our clinics typically don't have the chemical analyzers, but they certainly, some clinics would if they're a busy, very busy clinic. But this can be plugged in at the hospital, et cetera, and then other labs that we're working with. It could eventually be developed for point of care, and that's I think the bigger interest. But let me tell you about what we know. So this over here shows us that it's the line represents how well the relationship exists between this new assay and the way we did things previously. And they're very, very close. In fact, this the slope of the line is almost exactly a 1, which statistically speaks that they're very, very similar. So you can see that for the majority of blood levels, especially anything under the 800 range, they're very, very close, tightly knit. So it's an accurate device, and that's why the FDA approved the technology. Well, here's the differences between the two. The old is on the left that we traditionally use all the time, and the immunoassay is now available in our laboratories. The turnaround time is often 2 to 5 days. And if I had a poll for some of you in the audience, I bet you'd say it took longer than 5 days and sometimes to get these back. It does sometimes. And so we need a larger volume of blood. It's more expensive. There's no FDA approval or guidance actually on the assay or clozapine levels. So whatever's done is not guided by anything ever approved by the FDA. And so we're using a technology that we believe is an accurate technology, but the immunoassay has recently received FDA clearance. It's generally speaking less expensive. You could run it on site if you have the chemical or the clinical laboratory analyzer, and it's less than 30 minutes to get your result. It's a lower amount of blood. So often if you're in a hospital setting or in a community-based center where you have this available, you can have it run and results back while the patient is either in the unit or coming in for a visit. What we did, though, a few years ago, and we published this in 2020, I believe, is we actually looked at taking samples of blood from people and sending the same exact sample, dividing it up and sending some to a regular laboratory and some to this company to see what we saw in the real world with patients. So we looked at people who had schizophrenia, who were treated with clozapine, but then we also recruited people with schizophrenia not on clozapine, and then we had healthy controls as well. And as I mentioned, we sent these aliquots or these partial pieces of the blood to the site, so that came from the same batch. We tested it over and over again on a couple of dates, so we could look at the concordance, like how well, if you measure the exact same thing again, you get the same result. And this is interesting findings. So we sent it to a national reference laboratory, and the red is the national reference laboratory, and the yellow is the new immunoassay. We see very similar results in the clozapine treated patients there. You can see around between 415 and 480 nanograms per ml. The blood levels are similar. There's a coefficient of variance here that's less than 20%, which is acceptable for this type of assay. Usually we're looking at less than 30%. There is variability all the time, and you'll see on the concordance how variable it gets. But we see similar results. The middle section is the non-clozapine treated patients. The red is the National Reference Laboratory, and there's 0 for the immunoassay, so it doesn't show up. But the non-clozapine treated patients had some results of patients showing up on clozapine with the mean values of 30, and the same was true for healthy controls. In fact, these healthy controls have never been treated with clozapine, and the lab gave us results back of an average of 44 nanograms per ml with a standard deviation of 300. Saying that some people were actually showing a value of 300 than when they've never been treated with clozapine. And the immunoassay was 0. So there were no false positives. But this wasn't just happening in a few people. Of the 117, 18 people had false positives. So that's quite a few people. And so we think that it could be some cross-contamination at the lab. It could be that the technology picks up other things in the blood that look like clozapine or very similar to clozapine. It's a possibility, but more likely contamination. But it could be either or. The immunoassay had no false positives, so it was more accurate in the determination overall in what we had seen. And this is the correlation between the two. We see a correlation of 0.8. There's some variability. So this is looking at the relationship of both those techniques together. And so it's significant, meaning they're very similar overall in their correlation. This statistic, I don't want to confuse you, but it's called a concordance correlation coefficient, a CCC. And what it just tells us, if we repeat it several times, the same blood, do we get the same results? And the closer to 1, the value 1 means that happens, that's equal. And so with the National Reference Laboratory, we had a value of 0.869. And with the immunoassay, we had almost 1, which was quite... it tells us that you repeat it again, you're going to get the same results. So it's very consistent with how it reports from the exact same sample. So so we not only see it more accurate, but we see it more consistent over time. With the regular National Reference Laboratory, even if it's the same sample, we don't have a perfect correlation. You're going to have a 12, 13% difference seen all the time. The benefits to help transform care, we're talking about these point of care measures are really important. They really help transform, break barriers. Here with the point of care, so here with this assay, we're not quite at the point of care. It's only approved now for chemical analyzers at our hospitals, but no false positives. Results are quickly obtained. We can manage our care in real time when we have these. They're more cost effective. Insurance pays for it. We see the same, and we see not only accuracy, but consistency. So we would expect to have the right results come back time and time again. And as I mentioned, this technology is then available to be developed into point of care technology. So in some countries, it's already approved for point of care. In our country, it's not all the data has been submitted to the FDA yet, but we're hopeful in the next couple of years, we'll soon see something like the Athelis device, where we can do it right at home or right in the doctor's office. And we could have both of these done quickly to help transform care. To let you know about our work with Clozapine, in breaking down barriers, we've published several papers in this area. And this specific slide just shows our work with the National Association of State Mental Health Program Directors across the country. And working with them, we helped put together a national guidance paper on addressing the barriers. And we also subsequently published in a couple of other journals, but the guidelines are clear that Clozapine is recommended. And these guidelines we set forth are challenging the field to do better. And what it's pointing out is that we should be developing these kinds of technologies. We should be changing care. We should always be advocating for better ways to use Clozapine to break down barriers. And so, in fact, these papers mentioned the development of point of care technology is important, but they also point out that clinicians should be educating themselves. They should be lifelong learners. They should be embracing Clozapine when it's appropriate. We should not be passing up patients, but all systems of care should be from the prescribers through the hospital formularies, through all endpoints. Our system should be improving our ability to use Clozapine. Education is another barrier that psychiatrists had identified. So in addition to the point of care, this sort of ties in. So Matt and I have been working on a project along with many others from the state for over a year and a half now, where we've developed a program called Champion. It stands for the Center for Help and Assistance for Maryland Prescribers Improving Outcomes Network. And we use what's called Project Echo. It's a platform where we can provide telementoring and education to rural areas or other prescribers around the state. So we've been working on a project where we have a consultation line in Maryland for any prescriber to call in to ask questions about Clozapine, and that's open to any of you or your physicians or any people that you work with. And we've had 40 consultations to date, and we have a team of psychiatrists, psychiatric pharmacists, nurses, hematologists, cardiologists, physician assistant. We've lots of people ready to answer the question that it's appropriate. So that's available. But we gave that to everybody, but we gave everyone the Athelis device who was involved in our program. So any physician, psychiatrists that wanted to join in this program and learn and get involved with education was given a device. So there's many out there in Maryland. We have, I think, 50 or 60 almost out there in the clinics and hospitals around the state being used currently as part of the program that we've been able to implement. We were studying the education portion in a randomized design where half the sites got education and half the sites didn't. And we've recently just finished the educational program. So that's no longer open. However, our consultation line remains open, and that's champion-echo@schoolofmedicine.umaryland.edu. You could always reach out to NAMI or to myself or to Matt to get that consultation line. But that purpose is to break down barriers in people not feeling competent and people not feeling educated about clozapine. And we did a 26-week or 52-week, 26-session program to improve, so that we taught all the knowledge that we had at the central site, the hub site, to all the spokes or all the groups around the state to hopefully improve clozapine use. So hopefully we'll see changes in clozapine in our state by many of these initiatives that were going on. And this is just another way to disseminate the point of care devices and to break down educational barriers. I wanted to point out too that at the Maryland Psychiatric Research Center, we do have opportunities for studies related to clozapine. We have many, many studies and opportunities for people to get involved. Some of them are simple one-time visits, others or could be clinical trials, but there's a whole gamut of opportunities to participate in research. And it's not just for people with schizophrenia, but their family members or even healthy controls. Anyone who wants to participate has opportunities with us. But the few that I'll mention is that if you're a prescriber or if you're a family member, if this resonates with you at all, we have a national multi-site study happening where 7 sites across the country are enrolling people who have schizophrenia who may have had aggressive or violent act one time in the past 6 months, pushing, shoving, slapping, anything like that. And we're looking at the effects of clozapine in reducing this type of behavior. We believe that clozapine helps impulsivity. So when people feel impulsive, angry, or for whatever reason might act out, if that happens, we believe clozapine could be the best treatment if that happens. So we're trying to study that, and this will be the largest study to date to do this across our country. So it's a nice study where a physician can refer to us, and we could help. The patient stays with the doctor, but we do additional visits. We could transport the participant, the family member, anyone out to our research center in Catonsville, and we'll see them weekly. We provide compensation, but what we do is we work with the treatment team, and we will either randomize. And some of us are blinded to this, but randomize your patient to either clozapine or how you want to treat them, treatment as usual. So that means then you would switch them to clozapine, or you would continue the treatment or start a new treatment. And then any given time, you have the ability to change the meds, but it's really a naturalistic sort of real world study to evaluate how well clozapine's used, how well it works, and then how well people stay on it or switch from their treatment to clozapine. So it's the participants receive compensation. The study teams receive some compensation as well. We provide transportation. We check side effects. We watch closely. We work with you as you possibly start clozapine or the other treatment, and we just become part of your team. It's not meant to be cumbersome for your doctors or you as a prescriber, depending on who's watching online, but meant for us to augment care and provide opportunities where clozapine could be introduced, possibly if they're randomized to it, in an easier fashion, and there's compensation provided. So that's a nice new opportunity I'd like to share, and the phone number's there for that. Another current study is anyone currently taking clozapine could sign up with us. They come out for a one-time visit. They get a venous straw and a finger stick, and we're helping to validate the new point of care device that we were talking about today, and that you compensated for that too. And so it's a nice, easy visit. Compensation or our transportation's provided. But if anyone you know is on clozapine, it's a nice opportunity to introduce research, let someone see how important it is to be involved with making strides and advancing, and it could lead to helping us move this finger stick closer to care. I just wanted to thank everyone, especially Matt, who's been working with me in this area. He's very knowledgeable and has trained people from all around the state to use the Athelis device. In addition to helping to run most of these clozapine studies, we've run some studies in Africa looking at patients who have low white blood cell counts. We're getting ready to present or to publish this data. We have been working with clozapine from clinical trials to the public policy front across the gamut, and have a large team of people who are experts with clozapine. So we've been really fortunate to have grant funding to be able to help move the field, but we rely on our state. We rely on our patients across the state. We rely on our prescribers within the state to help provide and help get an interest in research so that these studies can keep moving forward. So we thank you for this. And I will stop sharing. And I think we can open up a time to answer questions.
Yeah. We have a couple questions in our question and answer. So I'd like to ask, anyone else who would like to put in a question, just go into our question and answer, our Q&A, and put your question in. Shannon asks, how do people get access to this device? Is it covered by insurance, Medicare, and or Medicaid?
So currently, as I understand it, the company is going after Medicaid and Medicare potentially for reimbursement. Right now, some of the clinics are paying for that, and we can connect anybody who wants to the company, to Athelis. We do know that people are getting the device. I don't know if Matt wants to say anything different. They've been evolving and very quickly becoming a well sought after company for their materials. They also have other things to manage adherence with their medications and other technologies. So we've been pleased to work with them. But Matt, has anything changed on the front with Medicaid reimbursement that you're aware of?
Not that I know of. There's a small Medicaid reimbursement that can be done, but that's about it at this point.
Okay. All right. So we also have a couple other questions. Are there any other free hotline programs for providers, prescribers, similar to Champion Echo, for assistance with other medications or monitoring other medication levels? And could you please share with us?
Sure. So there is one good resource, and it's funded by SAMHSA and the American Psychiatric Association, called the SMI Advisor. I can type that in there, but Serious Mental Illness Advisor, Matt did for me. But so SMI Advisor is a group that's had some funding to create a centralized hotline it's mainly for clozapine and long-acting injectables. So if this refers to long-acting injectables, there's a group of people that will answer questions. There might be some leeway if it relates to clozapine or long-acting injectables, but I'm not aware of any hotlines for other medications and monitoring, but certainly the group is very knowledgeable, a very kind group of people that will be willing to answer questions, and that's funded by SAMHSA and the APA.
Wow, thank you.
Mm-hmm.
Kathleen, also like to know, what other barriers do you see to the prescribing of clozapine? How frequently have you seen side effects in patients?
So there's lots of barriers across the system potentially, and that includes these logistical blood draw barriers, but also people worried about side effects and in just for pharmacies having it on formulary. There's lots of barriers that happen, and some of our own clinical teams are just nervous about using it or have not had the experience using it. So that's why we did the education. And so there are lots of barriers, and we're trying to break those down. So hopefully in our state, we'll see those starting to dissolve with some of these technology advances. But side effects do occur in some patients. The key is going very slow, and we teach that. We talk about very slow titrations, just changing the dose every other day or starting off very, very slow, because that's the key to avoiding side effects. We don't want to have side effects stop treatment, because it's much more important to continue the treatment. But we do see saliuria or excess salivation becomes the most frequent one. And our patients, there are things to do to treat that. And we spend time on education around that too. And our hotline can go over any of these side effects and walk you through and handhold and try to treat. But Pretty much every medical disorder is not a contraindication for clozapine. People used to think, oh, they have cancer. Our patient has, an autoimmune disorder. I can't put them on clozapine. That is simply not true. Clozapine is a life-saving medication that you could be withdrawing if you're too scared about that. So it's always about working with teams, making decisions together, and you looking at risk versus benefit. So there are side effects, but we can manage a lot of them.
Okay. And approximately how much does the device cost out of pocket?
So I don't want to speak to that exactly. We can hook you up with the
Okay.
team there because it has been a changing field for them. And for us, we've been working with them. So it falls under our sort of grant budgets, et cetera. So that's a very different. So I can't really speak to the exact cost of the device for everybody routinely out there, and just don't want to say something wrong that could be changing because I don't speak on behalf of them nor get paid by them. So
Okay. Great. Okay. Linda asks, what should someone do if they get COVID or another infection with regard to testing for their clozapine level?
okay, first of all, call your doctor right away and tell them you have COVID. I was at a talk at the APA yesterday, and the doctor from Emory said, "My patients, I don't want to find out later they've had COVID because the clozapine. What happens is the inflammatory markers will kick in. They will stop the metabolism of clozapine, and clozapine levels will go high. We would typically cut the dose by half." During an infection, COVID is one of those infections. Not just there's many other types of infections, but don't stop the medication, and don't stop it cold start. Call right away to your doctor and say you have COVID, and if your doctor isn't aware, they should be able to reach out to us right away. We would have experts on hand who have dealt with this. We would cut the clozapine dose back until the infection ends, and then we would start to introduce the dose back up. But that's important, or you could become toxic. But that you can manage it very simply, and it's really just decreasing the dose during the infectious time.
So what happens when they get the vaccine? Is will that
Yeah, that's a
affect
really
the
that's a smart question, Gertie. So
Lindy asked that.
yeah, it's not the same as having a full cytokine storm or cytokine reaction. We have a student this past year who was looking at the blood levels with clozapine, and after getting and I don't think there's possibly some raising, but there's not any great warnings against that. So we keep your eye on that, but it's not the same as getting COVID.
Okay. I have a question. What if you know someone who has a low white blood count? Do you
Yeah, no,
still recommend clozapine?
that's a good question. So we just finished a large study. Matt was actually in the senior coordinator on this, but we included 274 people from here and then Lagos, Nigeria. So we went to Nigeria because what we were looking for is we were looking for a Black population who have more likely to have a genetic, what's called a genetic polymorphism, and then have a lower white blood cell count naturally. And because of that, there were new guidelines that came out in 2015 to allow us to treat people with low white blood cell counts that might have what we call, it's referred to as benign ethnic neutropenia, but the term ethnic in there is probably going to go away as we start to understand it's more of a genetic variation and not really, because it affects mainly sub-Saharan African populations as well as Middle Eastern descent people. But if they have a certain genetic, you can easily draw this, if they have a certain genetic polymorphism, they likely have a low white blood cell count. And then people get scared. Our doctors, us, we all get nervous when someone has a white blood cell count that's kind of low. But we have to recognize, and our data shows this, we have to recognize that it's okay to run low. That's normal. It's not an abnormal thing to actually have a genetic, to be African descent and to have a low white blood cell count. That's not abnormal. That's normal. And so we've treated it as abnormal to date, and we've got to break those barriers down, and we've got to act like that it's normal, but that has us accept a lower white blood cell count than we would have accepted before. But our data will show, we're going to be publishing it soon, data will show that people can drop below 1,500, and traditionally that would scare people, but our patients do well, and we don't have a higher risk of severe neutropenia just because some of our patients who happen to have sub-Saharan African or African descent would have a low white blood cell count naturally.
Okay, great.
Yeah.
I don't have any more questions. Thank you for that answer. Okay.
Absolutely.
Oh,
There's
I
one
did
more.
have what is the advantage of at the list home, if you still have to get clozapine levels tested, do they have to be monthly? No, I think, oh, right.
No, I mean, the point is that yes, we still have to do some venous draws. I mean, there are still some things with clozapine, like when we draw lipids or we're looking at glucose, you still have to go sometimes for your baseline and some follow-up labs. And so, but the weekly white blood cell counts, typically in between all those visits, that weekly, the Thellus home is so helpful because that's all you need to do is that finger stick. Now, the blood levels, obviously we could monitor them more frequently if we had them at the point of care. But guidelines aren't exactly clear when to get blood levels, but they certainly, experts recommend to get it after about 2 weeks or once we get to a dose of about 200 milligrams to see where we're at, and then kind of follow up on a monthly. So the Athelis home still has all those weeks in between where it provides a benefit. And so, but the point is well taken that there still are venous draws that usually happen. But if people are very afraid of venous draws, we've had some patients who didn't want to get a venous draw at all. And so this has been their only option is the point of care device. Those people, we just have to furlough the blood levels. We furlough like the lipids, but it's a risk to benefit. Like it's better to be on clozapine, get your white blood cell counts at the point of care, and throw out those lipids if that's our only option. Obviously, monitoring is important, but we have patients who say, "I'm not getting any venous draws. I do not like the needle."
Right, right. So, are there any concerns for use of clozapine in the elderly?
Yeah, certainly we use it in the elderly. That's not a contraindication at all. We dose very, very low. We start with doses half of what we would start with adults. We're looking at like 6.25, very low, and go very slow. We're looking at sedation is a problem, and we can get to therapeutic levels. Sometimes we use this in Parkinson's dementia. We use it in something. There's other reasons why we've used it. We have a whole lecture. Well, we have a 26-week lecture series, but we do have a lecture on using an elderly, but we recommend just very slow. But yeah, the concerns are mainly about sedation and earlier toxicity, more side effects occurring just because blood levels get higher quicker. So
when you say elderly, are you looking at age 55 and up or 65 and up?
I mean, there's no cutoff for sure. I would think more when I talk like this, I'm talking more like 65 and above. Yeah.
Okay. All right. I think that's it. Oh, wait a minute. Here's something.
Oh, yeah. Okay. So I mentioned this 26. So yes, we're not releasing it yet, but we will be releasing our 26-week lecture series. It was part of a study that we finished. So we're still gathering the endpoint data and the Medicaid data on prescribing. So it will be coming out. When we get this out, I think when we get this out to all of our participants, we will, I think what we'll do, Matt, is share it with NAMI too, so that we can have these lectures. And the lectures span from introducing clozapine, dosing clozapine, titrating clozapine, constipation. We had a week on many, many topics. So we had a lot of information. And when we are able, it's still going to be a little bit of time yet, but when we are able to put all that up, it'll be a wealth of information because we had experts from our site. We put together a really nice program, and they were all CME and CEU accredited too. So that was really nice.
Awesome. Sounds helpful. Okay, then I think that's it. If anyone else has any more questions, we just ask that you would send them to connection@namimd.org or submit your question in your end of event evaluation when you get off at this session. And this is all. Thank you. We've had, wait a minute. That is all the time we have for now. So thank you all so much for joining.